Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot.
And today, I'm joined by Matt Waellert. He is the Chief Behavioural Officer for Clover Health. Matt, thanks for joining me today.
Thanks for having me.
So, first of all, I think it would be helpful for our listeners to hear what a Chief Behavioural Officer is and how you ended up in that role.
Yeah, it's sort of an unusual title. There aren't very many of them in the world, although certainly I'm on a mission to make sure there are more of them. So I'm, by training, a social psychologist, and in particular, I study in something called social psychology, in something called JDM, judgment and decision making. And so I spent my career looking at how do we create environments that change the way people behave. And when I came out of, I got somewhat dissatisfied with academia because they privilege the finding of absolute truth, which is really important in the world, but isn't always the same as making impact. And I think for me, it was more important to have impact. I'm a first-generation college kid from rural Oregon. It was really important to me that I made things better for people. So I came out of academia and joined a startup around personal finance. We were Mint.com's biggest competitor. So I started changing people's personal finance behaviors. And then we sold that to LendingTree. And I've sort of made that the rest of my career. And I was talking with a friend of mine who's one of the co-founders of Clover, Chris Gale. And I don't think we started the dinner with the idea that maybe I might come work at Clover, but we certainly ended the dinner with the idea that that might be something we want to do together. And I think what has increasingly, I hope people have recognized that, health behaviors are ultimately sort of going to determine people's health outcomes, right? We have a tendency in medicine to sort of look at the condition, treat the condition, but not recognize the things that necessarily sort of led to where we were in the first place. And I think we've newly realized that behavior is really important and people have become focused on it. Where we're still, I think, struggling is, well, who's really good in the world at changing behavior? I don't think people have looked to social psychology as much, although they're starting to, and I think that's great. So at Clover, what I do is run a team that there are sort of two models for behavioral science in an organization. One is sort of a center of excellence model. You ship me a question, I ship you back an answer.
Right.
And one's a more diffuse model, which is the one that we do at Clover. What I always tell everyone in the organization is if behavior is your outcome and science is your method, then you're a behavioral scientist. And so we try and empower everybody at the organization to feel that way. We do a lot of lunch and learns. We teach a lot of the techniques. But we do have a team that's sort of running the things that really we have to make sure get over the finish line. And so it's got some quantitative researchers and some qualitative researchers on there. So we might pose a question like, African Americans are less likely to get the flu shot than their white counterparts. This is a huge problem, right? 85% of the deaths, 70% of the hospitalizations for flu last year were in the 65 plus population. So Clover Health, Medicare Advantage, right? The majority of our population is over 65. It's a huge problem for us, and it matters a lot in the world. And so we can take a team and try and figure out, both from a quantitative perspective, what can we see from our data that tells us where this gap might be coming from. So, for example, we could interrogate questions like, well, people often get their flu shot at pharmacies. Are African Americans going to pharmacies as often as whites, right? We could look at claims data. We could look at where they live. Do they live farther away from flu clinics? There's lots of things that we can start to interrogate from a data perspective. But then we also have qualitative researchers. So we have people who are out talking to our members, calling blacks who did get a flu shot and blacks who didn't get a flu shot and saying, okay, what's different about these populations? What's different about whites who didn't get a flu shot and blacks who didn't get a flu shot? And then we come together as a group and then start to go through a design process with a project manager where we start to run interventions. And at Clover, we differentiate between three different kind of levels of interventions. We start with pilots. Pilots are what we call operationally dirty, meaning we assume they're going to fail, right? In science, you should always assume that your first attempt is going to fail. And so rather than, if we have to send letters, we don't go to the mailroom. We do it ourselves, right? Because we assume it's going to fail and we shouldn't set up a durable process. So we will run a small pilot for an intervention, try and do that same quant and qual sort of triangulation on top of it. Hey, did it work from a quantitative perspective? Did we see the data change? And also, did it work from a qualitative perspective? Did our members like it? Did it cause abrasion? How did they feel? Because that's actually really important in that process. We have to collaboratively design with our members. And if we can get behavior change, then we go into a test. A test is a larger, more rigorous, more formal. That's where we try and figure out that juice squeeze piece. One of the things that's actually been really interesting over the last year at Clover is we found it's not actually hard to find behavior change interventions that work. It's hard to find ones that work well enough and are scalable enough that you really want to blow them out, right? And that's a big difference from academia. Academia cares about whether it's true or not. Often they care about P over R, right? R is effect size. We really care about effect size. It has to be big because we have to be able to do it for a large enough population for it to matter. And then if the test works, then we go off to scale it, and it transitions to a team outside of mine, whether it's clinical operations or whoever would operationalize that.
So it's interesting that you bring up that expect it to fail, because you're not the first person on this radio show where I focus on these incremental improvements that has cited that as a specific, and I would call that, that would be my first learning point here, which is if you're going to try something, expect it to fail. That's
Absolutely.
Almost a mentality, because you want to be able to throw it out of the window and say, yeah, that didn't work, but we learned from it, essentially.
Right.
Yeah.
That's right. And one of the things that I think organizations are guilty of, and Clover has been guilty of in the past, although we're getting better at it, is, people do little tiny tests. They sort of manipulate them to look good, and then because they want them to look good, and then they just scale them to everybody, right, all of the time. And they don't take the time to really be aware, I think, of going through a rigorous process, because people perceive that it takes too much time. One of the big challenges to behavioral scientists is people are always like, well, won't this slow us down, right? And that's the problem with failure, right? People look at failures and they're like, that was a wasted time, right? And one of the things that science, I think, has to contribute to business is the notion that there's no such thing as wasted time, right? The only wasted time is if you're sort of verifying something you already well know, or not instrumenting something that you can learn from. But as long as you're learning from it, mistakes and failures are fine. And that's why we have that constant quant-qual sort of validation step going in there, because we can, quant may say, yeah, that didn't really work. But if our members are saying like, yeah, that really, that got there, right, then we know we're on the right track. And even though it's a technical failure, right, it didn't change the behavior, that qualitative feedback can give us we're really headed in the right direction or not.
So, and you specifically brought up the flu vaccination as a problem. That's clearly, a major issue. The take-up rates are just appalling in this country. In fact, I just did a piece, was shocked to discover that adults are in the 40% range, kids a little bit higher, and, it trends downwards from, the younger age to older ages. What have you found? What kind of things have worked, or have you found any?
Well, I think we're at the flu work right now. We're just sort of starting as we go into flu season. One of the hard things about doing experimentation around flu is there really is a seasonality to it. Right. People are paying attention to it. The vaccine's only available at a particular time. But I think we have some early progress, actually. And one of the things that really, I think, makes Clover distinctive, because we have a strong technological back end, it's really easy to gather data. It's both easy to get data that we already have into one place so that we can get our arms around it, and to collect new data. And so one of the things we actually did earlier this year was something that seemed totally intuitive to me as a behavioral scientist, but like every time I say it to medical people, they're like, seem shocked by it, which is the normal medical script for something like flu shot is, hey, Nick, did you get your flu shot last year? No? Well, you should really get your flu shot, man. And nobody asked what seemed to me to be the natural question, which is, well, did you mean to? Right? And it turned out about half of our members had every intention of getting a flu shot and just weren't able to make it work. They didn't end up at a pharmacy, or they just couldn't get it to happen for totally structural reasons, what in behavioral science parlance we'd sometimes call inhibiting pressures, right? They had the motivation, but the inhibiting pressures were sort of kept them from doing it. The other half had no intention of getting a flu shot in the first place, right? It was a motivating problem. They had no intention of ever having done that. But because nobody had ever asked them the question before, right, everybody gets the same letter. Right. And the letter is always pissing off half of the population. Because if you say, well, here's where you go to get a flu shot, half the population is saying, well, I don't want to. Right? And if you say, you really should get one, half the population is going, I know. Help me do it. Right?
So I think you're not just pissing off half, you're pissing off 100%. Basically.
Right. If you're doing both, I mean, it can be really hard from a communications perspective. And so I think just respecting people's agency, and we've gotten the habit of asking that intent question. We now ask it about lots of things. You know, do you exercise? No. Do you want help? Did you mean to? You smoke. Do you want to stop? Right? Was that important to you or no? And really trying to privilege what our members are telling us about their own health motivations. So at Clover, we really look at two different kinds of gaps. And one of the gaps is one that I think is really most people intuitively get, which is this intention-action gap. It's become very popular because of a bunch of really great behavioral science books. Right? People get it. I mean to go to the gym, I don't go to the gym. I have this intent, but it doesn't happen. But there's a separate kind of gap we've been spending more time on, which is what we're talking about as an intention goal gap. So meaning my goal is I want to live forever, but I have no intention of getting the flu shot, right? So I don't even intend to do the behavior, and it's incongruent with the goal that I have. That's another place actually where we've had a lot of luck at Clover, is starting to understand in a structured way people's motivations. So we actually ask people, members in their own words, why do you want to be healthy? Like, what's important to you? And it's been fascinating actually to get that data back, and we then put it into a regular sentence, right? Do some editing of the language itself, and then we categorize it. So we tag it with family and different kinds of things. But what that allows us to do is, you know, let's take this flu shot communication, right? So now I've got one piece of data, which is intent. Hey, I know Nick meant to go, but didn't, and Matt had no intention of going. So now I can send them a separate letter based on that. But I can go one step farther. I can say, I understand Matt's motivations. Matt has told me that the most important thing for him is staying healthy so he can play with his grandkids. That's his thing. Reason to be healthy, play with grandkids. So now I can write him a very targeted letter that says, hey, Matt, you know, you've told us it's incredibly important to you to be able to play with your grandkids. Did you know that they're a vulnerable population for the flu, right? And that when you get a flu shot, it actually protects your grandkids because somebody has to get the flu from someone else, right? And so, right, your grandkids can't get the flu if they're not around anybody who has the flu. And so you protecting yourself can protect them. That's a great intervention, right? We've now successfully moved the motivation away from Matt to his grandkids. Great. He's told us that's important to them, right? We know what he intended to do, and we can start to do these really personalized communications, but we can do them at scale. We can do them programmatically because we've coded that data, right? And, you know, it's essentially just a giant mail merge to be able to say, you told us X is important to you. You told us Y is important to you. And that's really actually been, you know, you talk often, Nick, about sort of like small changes that can have big effects. Just asking the question of what, you know, sort of the basic motivations for that person are can be incredibly helpful. And it's not hard. I mean, it's not a big thing. It's just something that you have to take the time and the energy and stand up a system to do.
It always reminds me of sort of one of the principles in my own world of medicine and treatment is that nobody gets up in the morning with the intention of being unhealthy.
Right.
At least I don't think so. I mean, maybe there are some people, but I think the majority of people want to get up and be healthy. And, you know, you're right, defining what that is. Nobody gets up with the intention of wanting to eat poorly, necessarily. And we just don't understand partly the drivers. And I think, you know, that's especially true that vaccination is such a hot topic.
Absolutely.
That, you know, there's this huge pushback that seems to be founded in lack of understanding, lack of knowledge. We're not communicating. And, you know, what you describe is capturing the right terms or the phrasing that really resonates with that group. So as you try and sort of pull that together into guidance for people listening, how do they think about it in their world? How do you get to that point? I mean, it sounded like one of the first things you said was, well, ask the question, you know, ask what people are thinking, what motivates them. But what's next? What do you do after that?
Yeah, I mean, I think that you have to build the systems that allow you to do something programmatically on that. And I think you made a good point in there that I think was one of the very first points when I came to Clover. When I first blogged about sort of coming, it was very central to my blog, was the idea that people want to be healthy. Everyone wants to be healthy, right? It is not a failure of motivation. It's it's environment, it's other things that are going on, and that we as practitioners need to assume positive intent. We have to assume that people do in fact want to be healthy, and we need to make that easier for them to do. And there's very psychological barriers to doing that. It turns out one of the things that happens, there's this thing called the actor-observer bias, where basically when I evaluate other people's behavior, I tend to ascribe it to personality characteristics about them. Whereas when I evaluate my own behavior, I can recognize the environmental things. Oh, I didn't eat healthy because I was on the road. I can recognize that. But Nick did it. Nick's just lazy, right? It's about his personality, right? And so when there's a failure to act in a healthy way, we assume it is in fact about something about Nick. And I'm just relentless at Clover. Anytime somebody says something that sort of is patient blaming, we always sort of try and get people to stop and step back and look at the environment and say, hey, because it turns out that those are really the salient, powerful things. And I think that's where, I hate the term, social determinants of health as if they were somehow special, right? They're just determinants of health, right? Like everything else in the world, they affect our behavior. And we should treat them not as some secondary class of determinants, but in fact a primary class of determinant that we should be concentrating on. And part of that's just backed up by Clover's an interesting plan. We have twice as many people of color as the average Medicare. Medicare is 80% white, which is crazy. Medicare Advantage is 80% white. And so in part because of the population that we have, I think we're so much more cognizant of the environment in which those people live. Environmental racism is a huge piece of what's going on in people's health. Medical racism is a huge part of what's going on in people's health. And so I think having a different population has invited us in some ways to think differently.
So for those of you just joining, I'm here with Matt Waellert. He's the Chief Behavioural Officer from Clover Health. We were talking about the sort of differences, and you were talking about ethnic origins as one of the elements. There's obviously geography, where we come from or where we're living. How do you go about teasing out improvements in those populations? Is it customized down to the individual, or how do you expand that out? I know data helps you get to that individual, but I don't think we're quite at the point of being able to say, right, we can do everybody individually. Yeah. How do you tease out these factors?
Yeah, I think so what data often does, this is why that quant-qual pairing is so important for us, along with a project manager, someone who has behavioral science experience. We were looking at something actually where we were struggling a little bit on the CAPS question around getting needed care. So we were digging into hey, people are saying it's hard to get the care that they need sometimes. Let's try and figure out why that is. So one of the first things we thought was, hey, maybe to your point, it's about geography. Maybe people have to go farther to their doctor, and that's going to make them feel more negatively about that. It turned out that actually wasn't true. People who were saying it's easy to get care were actually going farther to their doctors. They were just going to better doctors. They were going to higher rated doctors. They're higher SES people who had the luxury of being able to travel farther. They were in relatively good health. And so they could go farther to a doctor that they liked that could provide better care. So we noticed, okay, actually the people who are struggling with getting needed care are actually going a smaller distance. Well, maybe they just live in areas where there are bad doctors. And so we started to look, and what it turns out is they actually are somehow selecting bad doctors. So meaning there were good rated doctors in the same geographic area. These members just weren't managing to find them because of a variety of things. But that was so great, data tells us that. But that's where that operational excellence really comes in. That's where you have to have that operational layer. We have a really, just amazing member experience team. The average, when you pick up the phone at Clover, it's actually funny. I was testing a bunch of language about Clover, and one of the taglines I questioned was Clover, the insurance company you might actually want to call, right? And people love that. And it's true. If we look, we have all this data that shows that actually our members love to talk to us far more than the average plan. And I think with that then, that trust relationship actually allows you to then do unique things like call Nick and say, hey, Nick, you said you're having trouble getting access to care. I notice you're going to a doctor who other Clover members have really rated poorly and you've rated poorly. Can I suggest another doctor that might be better for you? Right? And right now, to your point, we do that at the, okay, well, what did all Clover members say about a doctor? Right. What we want to get to is, hey, what's the right doctor for Nick?
Yeah,
right?
The Netflix matching kind of
exactly.
Yeah.
But it's not actually that far away, right?
No,
I mean, as you start to build out these data models, we have a great machine learning team, and really the poverty there is about data. And so as we get richer data sources, and that data is generated by asking our members, by talking to our members. It's amazing to me how many plans and how many health systems, we run this survey because we're required to run this survey by the government. And then we get the data and we see what our STARS payments are going to be, and then we drop the data off, we never look at it again. And I'm like, or we identify gaps and we try and go close those gaps. But there's meaningful stuff in that data. Those are your members telling you, hey, this is the doctor I go to, and I wait a really long time for appointments there. Right? That's valuable. I can give that back to a doctor. I can say, hey, did you know that your members are having trouble? What can we do together? Let's figure that out. I can give you a report card on where you're doing well, or not doing well. All of these things, it's just amazing to me how much data people just drop on the ground. And so I think if you start to operationalize that at scale, and then you have a good, strong relationship with your members, you can do things like active steerage, right? Where you can sort of say, hey, you've told me that's not a great sort of doctor for you. Let's find you a better one, right? You get permission to do those things, right? It goes back to that intent data. Yeah. We just ran a campaign the other day, actually, with really crazy high results. Because we asked people, hey, do you work out? Would you like our help to work out? And by the way, 80% of members who don't work out said they would like our help to start. Right? I want help to start. Well, that permissioning, now when I do a campaign, I can call you and I can say, hey, you told me you want this, right? I don't have to try and sell you something you don't want. You told me you want it. So I'm going to take that intent and use that to start the conversation about what we then need to go. And using that kind of targeting, the average, campaign uptake rates are 3-5%, right? 75% of the people that we call either signed up for a gym tour, asked us to send them gym equipment to their home, wanted a workout buddy, or wanted to know where the nearest gym was. So we had 4 potential things that could happen. 75% of people took one of those 4 actions because you knew in advance, you had high trust, and you could act on their previously expressed intent, right? Which I think is really, really key.
So it's interesting. I mean, I think of Pandora and Netflix. They're both really good at predicting things, and they get my permission because they've asked, and I give them feedback. So this to me feels very much like those sort of concepts. We're almost out of time, and I want to just maybe pick your brains on a personal level for the thousands of folks who I know struggle with this. I want to do good. I want to get to the gym. I want to be healthy. Can you tease out one sort of piece of guidance to close out to say, this would be one way? I mean, I'm not looking for the answer, but more the approach.
Yeah, absolutely. Yeah, I mean, I think there's a variety of answers. I'm going to go with the one that I think is scientifically backed and is also the one that in my, I've been doing this for 15 years, that seems to work the best. And that is, control your environment. Recognize that you're going to get busy and you're going to get tired, and mental resources are going to get constrained. There's a saying that we sometimes that I really try and drive to people at Clover, which is if you make the right thing the easy thing, everyone will do the right thing. And so if you want to go to the gym, it's not about, there's a million motivational things that you can do, and those all work sort of, but the easiest thing that you can do is just make sure that it's really easy to go to the gym. Right? The easier you can make it. Or, conversely, if there's a behavior you're trying to eliminate, make it really hard. It turns out if you don't have candy in the house, you don't eat a lot of candy, right? The single best thing that you can do to control your eating is to control your shopping, right? If you control how you shop, you control how you eat. Because, you know what? When it's 10 o'clock at night and your willpower is low and you're cognitively tired, right at that perfect moment that you would dig into a pint of ice cream, if there's no pint of ice cream, you're not going to do it. And I don't mean that to suggest that people should live terrible, miserable, impoverished, sad lives. I don't mean that. I mean, figure out the healthy, go get some Halo Top and have just one pint of Halo Top in your freezer that's so that if your motivation does feel, you've got the right thing there. So I would say it's control your environment and really think about inhibiting pressures, right? So either make it hard to do the wrong thing and make it easy to do the right thing.
That's perfect. Great way to finish. I love the sort of concept of changing the environment. It sounds simple, but it's not. It's going back to almost root cause kind of analysis. The reason I eat that pot of ice cream is because I bought it or somebody bought it for me. So that's fantastic. It just leaves me to say thank you for joining me on the show. It's always a delight to hear you. I love the insights. I think it's such an important part of healthcare and medicine that's missing. So thanks for joining me, Matt.
And thanks for having me, Nick. I appreciate it.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at DrNick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.